This is the roundtable by WFNS Skull Base Committee. Today's scientific session is craniopharyngioma. I am a co-chair Dr. Dushik Kong, Samsung Medical Center, Seoul, Korea. And I'd like to introduce Dr. Daniel Privedello, co-chair of the Skull Base Committee. And today we have 4 panelists consisting of Dr. Daniel Privedello from United States, and Dr. Francisco Guzman from Colombia, and Dr. Francesco Doglietto from Italy. Is it right, Francesco?
Yeah, that's perfect. I'm impressed. Thank you.
And the Dr. Semi Youssef from United States. Before case presentations, I will present the general concept of craniopharyngioma very briefly. Can you see me? This slide?
Yes.
Yes, craniopharyngioma is very rare malformation tumor of low histological malignancies arising around the craniopharyngeal tumor. And it is composed of 2 histological subtypes, adamantinomatous craniopharyngioma and papillary craniopharyngioma cases. Adamantinomatous type is driven by somatic mutations in CTNNB1, and papillary craniopharyngiomas have somatic BRAF mutations and are typically solid tumors. And clinical manifestations of craniopharyngioma include ICP sign and visual impairment and endocrine deficiencies. This is absolutely long-term survival, and it is benign tumors, but the quality of life after surgery or after treatment and neuropsychological functions are very frequently impaired because of the very near anatomical proximity to the optic chiasm, hypothalamus, and pituitary gland. And it is located, can be classified according to the location of the craniopharyngioma by Dr. Wata, and it can be accessed with several types of the surgical approaches. And then I will skip it. And the first case presentations will be given by Dr. Francisco Guzman from Colombia. Would you please start? Ooh.
Francesco, you're muted.
Okay, here we go.
Yeah, better. You just need to share again, I guess.
Yeah, here we go. The first case that we are going to present is a lady of 62 years old. It's a case with a lady with 1 year of apathy, and it's going to be with a progressive tiredness, drowsiness, and finally, after multiple consults, the patient is referred to neurology, who order an MRI and results in a big tumor in the skull base. The patient is referred to a skull base neurosurgeon. Is coming to my consults. I see the tumors and I perform several labs, and the patient results with hypopituitarism and DI. The DI is very important in the patient. I hospitalize the patient. We improve the thyroid hormones. We improve the cortisol. We improve the diabetes insipidus. And in the physical exam, we have a patient with severe confusion, visual impairment. She get a little bit better with the thyroid, but the confusion didn't improve too much. The patient was very thirsty at the beginning, but decreased with the desmopressin. the patient had a decrease in the motion and walkiness. And the MRI showed this huge lesion that you see is a lesion that have a mixed component. They have a solid component, paracellular, between the carotids, and have a kysted component that really compress the third ventricle and have a cystic component that really compress the hypothalamus. So I don't know if you want to discuss first, maybe this with the panelists, the kind of approach that you want to do with the patient before that I show you what to do with the patient. Any suggestion? What you will do, or we continue?
No, let's discuss. Yeah.
Okay, I will continue. The decision that I took is that.
Let's discuss, Francisco. Let's discuss.
Yeah, I mean, looking at it, this tumor is all behind the anterior cerebrals and pointing into the lateral ventricle. So one option is to do interhemispheric transcallosal, or you can do subcallosal translamina terminalis to get there, but endoscopic would be almost impossible. You can do terional as well, trans-wide, trans-sylvian, but I would say anterior approach, either transcallosal or subcallosal.
Okay. Any other suggestion?
In my opinion, I think the endoscopic transnasal approach can be done because the most part is cystic, and if we can deflate the tumor, I think we can approach via transnasal approach. Yeah.
Yeah, I would like to. Sorry, go ahead, Francesco. Go ahead.
Yeah, sorry. I would be very interested in understanding where the optic chiasm is. I'm not sure. I can see it on the. I'm not sure about it on the sagittal.
We have a very discussion with the neuroradiologist. We think
okay.
the chiasm.
Okay, so if that is the optic chiasm, and I would agree, this is an infundibular craniopharyngioma with a solid portion that is approachable with a transtuberculum approach, and the infrachiasmatic corridor seems it's small, but it's I would say large enough to address this with a transtuberculum approach. Which would have the benefit of relatively limited manipulation of the optic chiasm.
But this tumor is above the optic chiasm, right?
Well, it's above on its cystic component.
That's the whole idea of endoscopic, that it gets you below the chiasm for a regular craniopharyngioma. I mean, most of the craniopharyngiomas are endoscopic now, like the great majority, but there are exceptions to the rule, including this one. But let's see what Dr. Guzman did in here.
Yeah. Well, let's just.
So I will share you my appreciation before surgery of this case. First and all is that it's not common that you have a DI, I mean diabetes insipidus, before surgery. But I am very familiarized with craniopharyngioma. I have a huge cases, and when the patient have a DI, most of these patients, the craniopharyngioma is infundibular. So it's in the infundibulum. You don't find infundibulum in this surgery. So it's a good tip for the audience. When the patient doesn't have DI, you can find infundibulus just like moving around. And the other thing is I agree with Dr. Soishi. When you have a craniopharyngioma with a kystic component, it's going to decrease, and I feel very comfortable with the craniopharyngioma doing endonasal, no matter the site. I'm not confident with the endonasal approach when the craniopharyngioma have a very lateral extension. So in this case, I choose an endonasal approach. I have to be honest, more than 90% of the craniopharyngioma, no matter if it's child or adult, I do endonasal. The result is very good. This is the surgery. I'm going to advance a little bit, and this is the dissection. I do this is the hypophysis, as you can see. I do an arachnoid dissection. You can find here the chiasm. It's in the place that we told with the neuroradiologists we are planning to see. This is the carotid, this is the pecum, this is the superior hypophyseal. We are doing arachnoid dissection. I love to do arachnoid dissection. I don't go for the tumor at the beginning. Then I try to do the dissection, like arachnoid dissection. I am not in the beginning aggressive trying to move the tumor until I have a very, very good plan of dissection. So I do the dissection in the arachnoid plane. So I found here the other artery. So I have here the craniopharyngioma dissection in the posterior plane. Now in this point, I try to take out a little bit the tumor just to have a better view of the tumor. And here you can see the tumor more further the chiasm. So I am like moving the superior hypophyseal artery, just going to the third ventricle and just moving a little bit more, just following the arachnoid plane. I just dissect the craniopharyngioma, just following the arachnoid plane. And if you are seeing that now I am like peeling the capsule of from the hypothalamus gently, and you can have the capsule of the craniopharyngioma out from the hypothalamus without damaging it. So in some cases, some people say that the capsule you cannot resect it, but in most of the cases you can resect the capsule in this patient. So at the end of the surgery, I'm going to move a little bit. At the end of the surgery, I'm taking this capsule out, and at the end you have this view with the final capsule taken out with an excellent view with all the tumor resected. This is the foramen de Monroe. This is the fornix. You have all the tumor out without the capsule, the third ventricle, the carotid in here. So the patient did very well. Actually, have a very good MRI resection, I see. And this is the patient 2 weeks later in my office. So it's a good. I think it's a good case to discuss here.
Yeah, Dr. Francisco Guzman, thank you for your nice presentations. It's an excellent surgery. So I have one question. You commented about the tumor capsules from the hypothalamus, and then how to differentiate the tumor capsules from the hypothalamus. So actually, it's very challenging to differentiate maybe some tumor capsules or too aggressive surgeries can injure the hypothalamic thalamus.
Let me I don't know. I think is you can see with the time you can feel the difference. The arachnoid is more like transparent and plate. I don't know, like silver, like transparency and silver kind is the arachnoid, and the capsule is tinted with these green particles of the craniopharyngioma. I don't know if you got me. So when you have the calcium, you have this green thing. I think is the thing with the capsule is I'm feeling that is the same with the meningiomas. If you find the right angle and the right dissection, you can peel the capsule and take it out.
Well, histopathologically, the craniopharyngioma capsule interdigitates with the brain pia, and there is no arachnoid.
Not always. When I found that, it's the same with meningiomas.
It's not meningioma. This invades the craniopharyngioma capsule. invades the hypothalamus. So
Not
I mean,
always.
if it's not coming off easily, I agree with you. If it's coming off easily, go after it. But if it's not, then I
Yeah.
think we need to leave something on the hypothalamus.
I agree, completely agree. I mean,
And
what I'm
that's,
trying to say is that if you find the plane and you can dissect it and you find that the capsule is you can dissect it very gently, you can do it. I mean, you have to be patient, you have to do it gentle, and the capsule is moving, do it. But sometimes it's the same like meningiomas, is taken to the pia madre, the same that meningiomas, you have to leave it. There's no way. And in that case, you have to be honest. The tumor is going to regrow. There is no way. The tumor is going to regrow. So,
Francisco, I think that's one of the main advantages of coming endonasal is actually to the angle to help you to make that decision. I think, Sami, like you're saying, because I think the endonasal view, because allows you that directly visualization of the walls of the hypothalamus, help you to make a decision if you should stop or not. So one thing that I do is, like, as I start peeling that from the hypothalamus, if I start seeing too much petechia, then I stop. Then I just decompress and leave just a membrane on the hypothalamus to avoid damaging, exactly like, because you're saying, because that specimen, when you take it out and you send to pathology, they do see brain tissue attached. You basically avulsing. The way I explain to the patients is it's like you put butter on top of bread and you try to lift the butter and you see pieces of bread coming with it. So I try to explain that to lay people. But that was
Danny.
Can
I have a question to Danny. Is that okay? Do you think we should make any difference between right or left to examine the how feasible the tumor is going to be resected? So maybe we should try to resect the tumor on the right side first. I mean the capsule, because the right side is most for most patients it's not non-dominant side.
It's a very good question. I never thought about that, to be honest, but now that you brought up, I think that's not a bad idea.
I think it depends on the parainfundibular corridor, whichever is opened more than the other, because you usually don't have the infundibular midline, it's deviated to one side. And when the tumor is pointing endoscopically toward you, I think that's what we tend to go for.
I think anteriorly, Soichi, I think anteriorly probably doesn't make much a difference, but if you have adherence on the mammillary bodies, the left mammillary body, it will be much more, like function or, like in terms of memory pathways for the patient. So I think posteriorly, what you said probably has a good, reason to have that type of strategy.
Okay.
But we'll let Dr. Dusik continue.
Can I just ask a question to Francisco?
Sure.
Because we're obviously discussing on different types of craniopharyngiomas, extraarachnoid, extrapial or subpial. I usually try and look at T2 images, and if there's a marked edema on the hypothalamus, I get a little bit worried. I'm not sure whether you have the same experience. It's obviously for you and the others.
Excellent question. Not only T2, but also diffusion. When you have this T2 and flare in hypothalamus, increased signal, and you correlate in the surgical, when you find it's going to be attached in the hypothalamus. So it's true. It's true. It's a very good correlation. Not always, but it's a very good correlation. To be honest, the good thing with the endoscopic view in craniopharyngiomas is I agree completely with Danny, and that's the reason because I do craniopharyngiomas almost always endoscopic, is that you have all the view in the front and you can dissect it. But I agree with you, most of the cases that you have increased signal in T2 flare and diffusion in the hypothalamus is going to be a pain to dissect it, and most time you have to leave a little piece behind. I agree completely.
Yeah. And is there any questions about this case? There is no questions. Let's move on to the next speaker. This is Dr. another Francesco Toglietto. Would you please?
Yes, thank you. So it's a real pleasure to be here. I would like to thank Professor Kong and Daniel Provedello for including me. Can you please confirm that you're seeing my slides?
Yeah.
Okay. So what yeah, this is my disclaimer, nothing really relevant for this. What I thought I would do today is present to you the first case I did just after coming back to Rome after 8 years in Brescia. So I moved last November. And in December, a colleague of mine came in and discussed with me this case. So it's, as you see, a young woman with a recent history of headaches and short memory loss, which led to the MRI that you see. Then once we started talking with her, it was evident that she had complained of depression and weight gain in the previous few months. And then I had a story of amenorrhea since 2007. But the clinical picture was kind of complicated by the gynecological surgery. And so I have more pictures. I'm going to go through them with you. As you see on T1, the cyst was relatively hyperintense, clearly hyperintense on T2. On the sagittal, you kind of confirm that the mass is mainly cystic, and then there's some ring enhancing. There's a really relatively small pituitary gland, she's 30, and a really small pituitary stalk. And on T2, you see some hyperintensity just below the optic chiasm. And these are the coronal images. Again, mainly cystic tumor occupying the third ventricle. So we immediately asked for some extra exams. We got the CAT scan, and as you see, as we expected, there are some calcified portions at the level of the capsule. There's some initial dilatation of the right lateral ventricle. And we obviously asked for a pituitary screening, which is here. And as you see, there's only slight hyperprolactinemia, and the gonadal axis is low, but otherwise it's fairly normal. So at this point, summary is we have a tumor which is in the third ventricle, mainly cystic. Maybe a small solid component at the level of the infundibulate recess. The patient is young and their pituitary function is normal, but she has headaches, memory disturbances that are very obvious, and has weight gain, so 20 kilos in the last few months. So what would you do? I'm not sure who wants to discuss this first.
What is her age again, Francesco?
30. She's 30.
Yeah, I think I just want to mention the age is one consideration on this, because I had a very similar case, but the difference is my case, the patient was like close to 80s. And then in that situation, I decided to just come with a borehole and it came with an endoscope and basically enter the cyst, decompress the cyst, and I was able to remove some of the cyst wall by using like a suckable, like a cutter device. But it was definitely a partial resection. I think the other consideration here is the fact that calcified, because I think one thing that this panel should be discussing, and I actually have a case for us to bring that up, is the differentiation between adamantianomatous craniopharyngioma and papillary craniopharyngioma nowadays. And because this is calcified, you know, is diamantinomatous, up to this day, the standard of care is resection. In this case, it's very challenging because the calcification it's around and large. And then you have a normal pituitary gland here as well. So this makes more challenge to go through the nostril in this case here. So
maybe another information that I should provide, because that was part of the discussion, is she's not married. As a consequence of her so-called depression, she broke with her fiancé, but when discussing on her future, she obviously would like to have children, and you know, that was brought up also as part
Francesco,
of the discussion.
do you mind putting the imaging slide?
Again.
Yeah, you know, I since I've been
Transventricular on this.
yeah, go ahead, Sami.
I'm just saying it pointing to the foramen of Monroe. So like you said, you know, you can come endoscopic transventricular and drain this, but you can see if you can take some of the capsule, but it's going to come back, unfortunately.
Right. I agree. That's what I said. That will be a better.
You can leave an Ommaya there, maybe.
If it was an older person, that was what I would do. Here, I agree. I think going with the more definitive plan, it will be better. But definitely, in the short period of time, the most important thing is the compression here. So, could you show the sagittal again? Like just the first sagittal MRI, just to see the optic again there.
Yeah, so
there is a window
to get
some of that tumor through there, but the problem is going to be the function, you know, pituitary function. So this is a very challenge tumor.
Do you leave a catheter there, an Ommaya, and you can do until she gets her family planning going?
Yeah, I agree. I think that's not a bad idea to go more conservative based on that function that is there, just decompress. I would definitely, this is one of those that in my practice, I sit with the patient and go through pros and cons and I evaluate, I think the personality of the patient also influences us to make a decision, because in my mind, I'm debating coming from the foramen Monroe with in a young person, I could do the same using a port. And I would be inclined to use a port and then do a transchoroidal approach to get a better view of the third ventricle and try to peel the walls from the top and be conservative on the lower part of the tumor. I think that would be better here than coming from below, just because of the function of the gland. But I don't know if Francisco has a different opinion.
And you can stage it, you know, if your pathology comes back papillary, then she's lucky.
Yeah, it's just unlikely because it's so calcified.
She has calcifications, which unfortunately.
One question.
Yes.
When you talk with the patient, that's what was she's idea? Because when I talk with, I do almost the same with like Danny. I really have a big talk with the patient. I had to try to be very honest with both and try to make a hard decision in the office and see what is the expectation, because in this case I agree you have like two type of approach, one conservative and one aggressive, to call it aggressive.
Yeah.
And
so
one,
maybe I'll go back to this. Yeah.
Yes, and one conservative who could be just drain the cyst, but when you do a conservative approach, I agree with draining the cyst, but you have to keep in mind that when you do a conservative approach, you have to keep in mind that maybe you have to return to the patient. So I don't have a very good. I have bad experience lifting an Ommaya and coming back to taking the tumor out, because it's going to attach to the hypothalamus, it's going to attach in a lot of the structures. So you have to be conservative. I just drain the cyst I just go, like Danny said, go to with the neuroendoscope in the foramen femoral, just drain the cyst, take maybe a little bit of the membrane, and that's it. I don't leave an omagia, and I go with the next approach when I have to be aggressive and go endonasal. But I don't leave omagia. I don't really like it. At least it's going to be the final thing that I do. So coming back to the question, did you talk with the patient what is going to be the decision? Because if the decision to the patient is that I don't wanna have children, it's not in my plan, and according to the question that you did before, it's not an enhancement, it's not increased signal in T2 in the hypothalamus. Maybe it's going to be a gentle capsule. It's not going to be a hard dissection. So can
Yes.
you tell us?
Yeah, sure. So the scenario was she's a secretary and she had to leave her job because of her memory loss. She's clearly depressed. She comes in with her parents. And so for sure, when asked, she says that she wants to have kids, wants to have a family. But that is also, a recent issue, as she broke up with her fiancé just a few months ago, and her depression was interpreted as reactive depression to that. And so I really appreciated all your comments. If you agree, I will show you what we did.
Yep.
The summary is young patient, normal pituitary function, mainly cystic, and headache, maybe leading to some initial hydrocephalus. So as you said, I thought I would add the priority of evacuating the cyst, resolving the hydrocephalus, and ideally preserving pituitary function while also reaching a final histological diagnosis. So that's what we did. It's actually one of the options that we discussed. And I choose this option really quite rarely, but whenever I have a mainly cystic portion inside the third ventricle and the pituitary function is normal, I've used this in the past in older patients with relatively good results, although the patient I do remember had radiosurgery because of a recurrence, and then she ended up being operated transsphenoidally. But this is what we did. So here we're coming in with the neuroendoscope. We haven't even focused properly, and we are aspirating the cyst. And then I start coagulating the capsule just to have an idea of how it behaves. And as you see here, it's really attached to the left hypothalamus. This is the left lateral wall of the third ventricle, and then cyst evacuation. Here I'm navigating inside. And the idea was to marsupialize it as widely as possible. So I'm sucking the content to reduce the tumor in a way, and also to look for the floor of the third ventricle. This is the specimen that we got, so a bit larger than foramen of Moro. And I'm making a 2.5-hour surgery. So I want to stress this. This is not a standard endoscopic third ventriculostomy. I'm making it really short. This is the basilar artery. Here I'm just looking for third, which we will finally see up there, just to confirm that there's a wide opening of the floor of the third ventricle, because in my mind, I wanted to have CSF running through the cyst. Once I realized that I would not be able to peel it away from the walls of the third ventricle. So then we left, as Sammy was saying, an omaya in place. And this is the CAT scan on day 1. So you see a cyst evacuation. The calcified portions are mainly all there. And this is the histology. So we got the confirmation that it was an adamantinomatous craniopharyngioma, and unfortunately with a relatively high proliferative index. And even in this histology, Dr. Jesse was pointing at the gliosis in the brain. So we send her home. She actually makes a good recovery. I'm going to show you later, but I just wanted to show you the first MRI at 3 months. And as you see, there's a solid portion, which is just above the infundibular recess. And she has already lost 15 kilos. She's back to work. Pituitary screening is unchanged. And this is the scenario. So what would you do now?
That's the very good question now, Francesco, right? So, the problem is not completely solved here. So, and it's an adamantinomatous. It's a very
normal
good
pituitary.
question. It's a normal pituitary. If you give radiation,
normal
it's going to be
pituitary.
gone. I'll tell you, like, this is the only problem with radiation in craniopharyngioma is when you do a beautiful job, preserve function, but if you need to use radiation in a residual or recurrence, you can count that the function is going to be gone.
Right.
So I would say for now, as you are now here, I'm inclined to just watch it for now. I'm not
Right.
going to throw anything there. I'll probably get an MRI in 3 months just to be on the safe side. That's what I would do next here. And then if it grows, then probably plan for another surgery. But for now, I would just observe.
Would you consider intervening if also she goes pan-hypo from the tumor? Then now it's ready to be taken out endoscopically.
Yeah, that's a good point. If that happened, do you have that information, Francesco? Was there any change on the function?
No, so pituitary screening was unchanged. So it's only slight hyperprolactinemia. She wasn't put on any replacement therapy. Yeah, so she's totally unchanged. I don't have experience of tumors not growing and causing hypopituitarism.
I would like to point, if you allow me, I would like to point that if you look very carefully in the post-op, the craniopharyngioma right now is very close to the interpeduncular space, so it's became very close to the perforators of the basilar, and in the hypothalamus still you have some plane in the left side. So you have to talk with the patient because very soon you have to do the surgery very soon before the tumor increased too much and the surgery is going to become more risky. If you can.
Yeah.
So I don't will run to go to surgery, but I think the surgery is better to be come soon as possible, and I'll do in endonasal. And of course, the patient most often is going to be panhypopituitarism post-surgical because it's going to be an infundibular tumor. But it's a patient with 30 years old, so surgery is going to be the best option right now because if you're going to irradiate the patient right now, the patient is going to be a pain in the ass in the years. So surgery right now, you have still a good plane. You still have a very good option of a complete resection.
We might edit that.
Yeah, so it's my advice in my point of view.
The way I'm not lucky with this, I'm just thinking here, after I said I would just observe, I can see this patient coming back 3 months later after this MRI with the tumor slightly bigger and pregnant. And then what?
That's a very good point.
Yeah.
That's actually, yes.
It's going to increase.
Yeah, that increases the complication.
Well,
Yes,
let her baby, then go and kill her hypothalamus, for God's sake.
Yeah.
That's actually a very good point, and we did discuss that and pointed out that we wanted her to not to think of pregnancy or anything. So all your points are very good. I'm just going to show you what we did. We got another scan at 3 months. And, you know, proliferative index maybe is not the perfect predictor, but this is what we got. I was hoping that maybe she would have a longer stable interval, but to be honest, I was already worried at the 3 months MRI. I couldn't see anymore the opening that I had done on the floor of the third ventricle, and here there's a slight but significant increase of the tumor.
Yeah.
So what would you do at this point?
I think, Francesco, this sequence also helps to show the patient the severity of the tumor and to bite the bullet, like we say here, and do like Francisco said. Now you say, you know, you expose this to the patient and say, you know, I'm sorry, you know, priority is your life. We're gonna take it out. And I think now that you don't have this robust extension and the corridor from the top is not ideal anymore there for a major dissection, I would say that in my mind, I would go endonasal, like Francisco said, and go for resection, and priority is not anymore the function of the gland. You know, you're seeing this as an aggressive tumor.
Yeah, agree. I don't wait anymore.
Sammy, would you have comments?
No, I mean, I do the same. Now the tumor declared itself. We give it a
Okay.
chance. We were wise, and endoscopic endonasal. I see a small window below the chiasm that you can go and get it all through that extension to the third ventricle.
Yeah, it sounds like we're on the same page, Francisco. I'm happy to see that.
Excellent case.
Yeah.
It looks like that's
So
what you did
that's
too.
what we did. And I was happier in a way because at this point, she's obviously very present. You know, she wasn't that present. She had memory disturbances before at first admission. And so we had the time to discuss all possible options. The options were already discussed at 3 months. And then, so we had the time to do some patient and family counseling, especially on what it means to be panapopit after surgery. So that's what we did. We went endoscopic transsphenoidal, transtuberculum. These are the major steps. I like to do the Haddad's flap on the left. We like to harvest cartilage or bone during the approach. Here is Dr. Matonio drilling. I always like to check my carotids with a Doppler. If I can, I coagulate on the superior intercavernous sinus just to have a clean field. I like to do this incision, and I like to have CSF coming out quite quickly. And once I have checked my hemostasis on the superficial planes, I do enjoy this dissection, as Francisco was saying. Here we had a dominant anterior superior epiphyseal artery coming from the right side, but as you see, the pituitary stalk was almost invisible. It was an infundibular craniopharyngioma. So here we're working behind the optic chiasm, and then it was, as you see, really tough and rubbery. So initial debulking. And at this point, I would use a 45-degree just to have a look at the dome. And here the capsule was really attached. You kind of see in transparency the catheter. And at this point, I just opened the ultrasonic aspirator. I don't think I would have been able to do it properly without the ultrasonic aspirator. And as you see, really rubbery, quite attached. And this is the almost final view with a 45 degrees, so basilar artery, both third cranial nerves. There was a small PCOM with a bit of craniopharyngioma almost attached to it, and that's the coagulated portion. This is the final portion, final vision with a 0 degree. And I would like to point out that I left the catheter in. but we're going to discuss this later. This is the reconstruction. I like to use a bit of gel foam to try and reconstruct the arachnoid, and then just a small layer of glue to decrease CSF pulsation. And maybe as Sami does, I do love fat, but I usually put it only at the level of the dural plane. And then whenever I can, I will use either bone or cartilage to have a rigid reconstruction, and I will cover that with the nasoseptal flap. This is the CAT scan on day of surgery. Obviously, we're looking at any hematoma and the calcified portions. And then I love to just check the bone window. So I will look at fat. We did put it here. Also put some fat in the infracellular recess, just so that the flap could adhere quite anteriorly to the planum. And this is the bit of gel foam with glue at the level of the floor of the third ventricle, which was obviously not there anymore. This is her MRI. I didn't point out, but even pre-operatively, there was some edema along both the hypothalamus. On the sagittal here, you can see nicely the fat. And after contrast, I was quite happy. Maybe a slight contrast enhancing on the right hypothalamus, which was where the craniopharyngioma was more attached. So I'm going to keep an eye on that. And on a small portion which is attached to the optic chiasm, I'm not that worried about it, but this is the other portion that we're going to look at. So histology obviously confirmed, but there was an intense gliosis and signs of chronic inflammation as they're described in craniopharyngiomas. She obviously became immediately pineapple pit. We put her on replacement for the eye, but we always check for the second phase of diabetes insipidus postoperatively. So we will not put give minorin at a fixed timing before 7 days. And unfortunately, she had a complication. So she developed a fever and her CSF was positive for Proteus, fortunately enough, sensitive to antibiotics. So we had to remove the catheter, and we checked her continuously and nasally, but we were confident that there was no leak there because the gel foam was still in the sphenoid sinus. And she, fortunately enough, she's had no visual or memory disturbance, and she's gonna go home on Monday because we operated on her 2 weeks ago. And with this, I think I'm finished. I would like to acknowledge the whole team here in Rome. I'm really fortunate to have amazingly experienced ENT colleagues and endocrinologists. But again, with this, I'm finished, and I will leave you for, I will leave the case to discussion.
Very nice, Francesco. The one thing that I was impressed to see how well was that ventricular catheter was put it perfectly in the foramen mayor. Gotta congratulate you that most of the time when we see these videos, the ventricular catheter is destroying part of the fornix and is in the hypothalamus. That one was really perfect. Beautiful, beautiful resection as well. So I think Dusik, maybe we have time for one more.
Yeah. Okay. So why don't you start, Danny, your presentations?
Oh, okay. Let me see here if I still have it. Just 1 second. Where is it?
Congratulations, Francesco. Nice case.
Thank you.
I see Kenan is raising his hand.
Yeah,
Maybe Kenan.
Do you want to say something, Kenan? me see here.
Can you hear me?
Yeah,
Yes, we do.
Oh yeah, I was not allowed to unmute and talk, but now. So first of all, I want to greet you all, my dear friends from the Skull Base world and from the World Federation and from everywhere in the world. I am currently on vacation. I was a juror in Memphis, but then they freed us, so I escaped with my wife for 5 days to Florida. But anyway, I really appreciate Danny doing this Zoom with all of you guys. This is great and important topic, craniopharyngiomas. I think the Skull Base is still a very important part of our WFNS committees, and doing this on a regular basis is very appreciated. Cases are great. I was able to see the case from Dr. Guzman and now this case from Rome. Very good. I personally do most of my craniopharyngiomas. I agreed with the first case with Sami doing cranioorbital with removal of anterior clinoid and going down. I like to have both hands available for dissection of hypothalamus because it's so tense structure, and this is where the decision about the outcome is made, state of the hypothalamus at the end of surgery. I do transnasal for the ones that are suprasellar, for just a limited ventral to the chiasm or ventral to the ACOM complex. Anyway, I won't keep very long since I've been in and out due to some internet connections, but congratulations, and I'm really glad that I'm watching and learning so much from you.
yeah, thank you. Let me just do here. Thank you, Ken, and I will continue with appreciate all your leadership, and we'll have one more case here. Will be interesting to see what you think as well. Let me just reorganize here, there. Yeah, so this can you guys see my screen okay?
Perfect.
Yeah, so this is the interesting case. I think it will complement all the discussion because it's a little unusual situation. So this is a doctor came to me having a little bit of confusion. The vision was actually fine, and he had normal pituitary gland function, and he had this imaging. And I just want to point it out here, like Francisco showed earlier. If you look at I always look at the anterior cerebral artery, the ACOM area, to define the optic nerve, like the radiologist pointed out to Francisco in the first case. Then you can see the optic immediately below the ACOM. That's the way it kind of helps me to find it. And the optic nerve is right there. The window we have in this case is very small here between the gland and the stalk, and to really enter in here, I always look at this angle to see if endonasal is a consideration. In this case, the pituitary gland was completely functioned, and this gentleman, a doctor, he was like really kind of trying to be as functional as possible. So we had long discussions with him here. The CAT scan had no calcification. Okay, I don't have it here, but that's zero calcification, and he was having edema on the hypothalamus, and that was kind of part of the confusion here. So I think we could briefly discuss, and then I can show what I did here. But I want to emphasize that there was no calcification. He's basically a very functional person. So what do you guys think?
Well, this is for sure a challenging case because of the edema, and the surgical window for the transfemoral approach is really small, and going transfemoral will give you the certainty that is going to be pineapple pit, and you might have a visual disturbance. So I start wondering about other options, so translaminar terminalis, and especially if we might be in doubt that this might be a papillary craniopharyngioma. I think this should be discussed, especially with a doctor, but even if it's not a doctor, because you might have other options with a partial, or I would say a subtotal removal Still, the challenge of preserving the pituitary function would still be there, but you could discuss removing the portion that is inside the third ventricle, checking how attached to the third ventricle it is. And if it's markedly attached, then you know you're not going to do a total resection anyway.
Yeah.
I would like to point out, Danny, that in this case is different to the others in two things. The first one is the one that you show us. The chiasm is very low, and it's a very low, very short window between the chiasm and the hypophysis. And the second thing, this patient has an infundibulum. And maybe it's a case that you can preserve the infundibulum and preserve the pituitary function. This is one of the few cases that you can preserve it. So in this case, maybe you can have a good dissection, and maybe it's one of the cases that you can have a very good dissection, not endonasal, but also pterional. I have a very good dissection and preserve the infundibulum. Could be one of those cases. I don't know what you are going to do, but could be.
Yeah, maybe let's just hear what Sami says, and then I'll show what I have.
But I think it's more of the same in terms of like multiple corridors that you can do. So you can start endoscopic transventricular to get a biopsy and see what pathology and go after that. Or you can do open from the beginning, either translamina or I don't have the axial, but it looks like you might do an approach to the interpeduncular cistern by widely opening the sylvian fissure through a pterional and have more space to dissect behind the vessels. So that would be the aggressive from the beginning, or in the transventricular biopsy first.
Yeah, you know, it's interesting. I really had that conversation with him as well, and then I consider coming this way, but if you see the ventricle in this case is not large, and the foramen Monroe is totally normal, and he's a doctor, and we talk about, he told me, I remember, like, don't touch my fornix. He said that. So that's the difference.
Might be on the back of this, but
but Francesco, I think we don't treat the doctors differently. I agree with you, but it's interesting. The questions that they ask is like, you know, they have a knowledge that is different. Is interesting. So I did exactly what Francesco brought up. So I end up doing a pterional with exposure here at the chiasm, and you see lamina terminalis was right there. I felt that was a good way to do it. I opened the lamina terminalis, and my plan here was to be gentle. I wasn't going for total resection, was to stay on the upper part of the tumor. I didn't want to go to the lower part. Of course, I told the patient we're going to inspect and see how it looks like, and see if there's any way to remove it, you know, of course. But then that's when I was looking for the lamina terminalis. I actually entered lamina terminalis, and then in one point, I put the endoscope as well. Let me see if I have it here. Oh, this is what it is. Let's let it run for a second, but I put I opened lamina terminalis, and I inspected all the way down there to see when it's open. I removed part of the tumor that was superiorly located kind of inside, inspected. There was a bunch of kind of vessels at the infundibulum. I didn't want to affect his function. This is the post-op. So, you know, basically all that mass that was on the lower part, I left there. I removed a big chunk that was centered on inside the ventricle. His pituitary function continued the same. I believe he had to start just one replacement. Maybe it was synthroid, but for the most part, he had normal function, and he confirmed papillary. It confirmed papillary craniopharyngioma. And then I had a conversation with him. This standard of care, when the papillary is still evolving, in Boston, they recommend radiation. And then they do have a new protocol that may consider BRAF inhibitors before radiation, but they have this concept that they do for 6 months BRAF inhibitors followed by radiation. We decided to avoid radiation. The patient want to try to keep his function. And we actually did BRAF inhibitor for 1 year, which is not, it's off label. It's not part of the protocol. And this is the MRI of this gentleman now. It's unbelievable.
Yeah, no radiation for this, exactly.
Zero radiation.
Beautiful.
We didn't do any radiation. He has I would say a partial function of the gland, but he is a minimal replacement. And his vision is normal. His mentation is back to normal. He's back to work seeing patients. And now this is a picture. We are more than 2 years out, and only did BRAF for 1 year. I presented this to the Boston team, where they came up with this technique with use of BRAF inhibitors, and they feel that we should give radiation to this. And I think this is still for science for us to discover in the future. And we don't know what is the way to 6 months of BRAF inhibitors or 1 year or even more. We don't know. We did for 1 year, stop, and has been stable without change for more than 2 years now. So I think this is, I always show this because I think this is part of the future of in our decision making. For
I think we have data already for 7-8 years about the BRAF 600 mutation.
No, we do, but the difference that most of them are radiation was also used either before or after.
Yeah,
So
I mean, there are literature about just chemo with really the tumor exactly like this. It's almost like a germinoma disappearing on adjuvant therapy.
Right, exactly.
But the problem with the radiation is that you are going to have a patient with hypopituitarism and memory disturbance. So
with radiation, yeah.
You can have a conservative only with inhibitors of BRAF inhibitors. That's enough. You follow the patient, and the patient with the years increase the tumor again, then radiate it, but not in the beginning. I think more conservative with inhibitors could be a good result.
Yeah, and this patient is extremely happy with the strategy. He participated on the decision making of this. He knows 100% is off label, and he promotes this. You know, like among others, like he is tried to bring awareness of that. He's a very intelligent man. And then I have to say that the interesting part of the story is that I'm doing now treatment on another doctor who was a neuro-oncologist who took care of this patient 2-3 years ago. Wow. So he basically, as a fellow, he was the fellow who prescribed the medication for this patient, and then he went there to work around the world, and then he called me back with a craniopharyngioma himself. In his case, I don't have the pictures here, but it's crazy because then I went endonasal conservatively because it was a little different tumor. I was able to bypass the stalk, confirm papillary, and now he's on 6 months of BRAF inhibitor, and the tumor is getting smaller as well. So I think this definitely changes the strategy, the way we do surgery for craniopharyngioma, particularly if it's non-calcified. I think I've been less aggressive on the non-calcified ones.
Benny, I have questions. How long is the follow-up?
Yeah, so two and a half years at this point.
It's too short still.
It is. I'm not saying that is the solution, and that's the criticism. I showed this in during WFNS, and the team from Boston, they criticized me saying that I should give radiation to the stalk, but I think he's enjoying some function. I'd rather just watch this for now. I agree that we don't know what we're going to do if he comes back. Should we start BRAF inhibitors again? Should we give radiation? We don't know. But it's a good discussion. I see that David has his hand up.
Thanks.
Craniopharyngoma is a benign tumor. The rate of increase is not very high. So if you have a very good patient that you can follow up, I think that you do a conservative only with inhibitors of BRAF, and don't irradiate. Irradiate a tumor, I don't know.
We have two members raising hands here. Kenan and David.
Hi, thanks. It's real sad we don't have access to these BRAF inhibitors where I work, but I have a question and your thoughts from the panel, please. If there's radiological suggestion that we have papillary craniopharyngiomas, would there be consideration for neoadjuvant, as in prior to surgery, given that it seems to have such a mass reducing effect, actually encouraging the surgery to be more complete? Would there be any consideration to use it prior to the surgery?
No, yeah, David. So I can answer to that because we discussed this. The neuro-oncologists that I work with, they are not comfortable using BRAF inhibitors without confirmation. The main reason is because it's not free of side effects. You know, if you look at the side effects, they do carry side effects. That doctor that I mentioned, he actually had side effects, but it was tolerable, so he kept going. But it's not free of side effects. So and it can be deleterious for not more than side effects. You can have, you know, some other problems with it. So it's just something to take in consideration. But there are some people trying to use as the primary treatment, and there's some people using radiomics. Basically using artificial intelligence to look at the imagings and create based on large databases associated with pathology, to then define based on radiomics to try to just treat it as you had pathology. But that may be also something in the future to think about. But I don't know if anybody has a different experience, but my experience is that they hesitate to give a BRAF inhibitor without pathology confirmation.
Yeah, nobody would give chemo or adjuvant without biopsy, so they have to have tissue to do that.
And in my country, for example, you cannot do any chemo or inhibitors, immunotherapy or whatever if you don't have a biopsy. So it's not allowed in my country, for example. So you need at least biopsy.
Just a brief.
Not even with imaging, you need biopsy.
Kenan.
Just a brief comment. I thought it was funny. Somebody said before we should not go through the nose because the patient is a doctor. But I know doctors, we are the worst patients. And thank you, Danny, for this great, honest description of the case where you showed that we are not gods and we can leave tumor behind. We should leave tumor behind sometimes. And doctor or not, I think we should at the end treat the patient the same way. One comment on your technique there. You're a great skull base surgeon and you did a beautiful approach. But I would suggest, Krish taught us along with Al-Mefti, once you remove the clinoid and open the falciform ligament, you create additional huge working corridor between the carotid artery and the optic nerve. And it increases progressively. So basically, you could actually, you did a beautiful job, but you could maybe go also between the carotid and the optic nerve on the right side, as I saw you were coming from the right side, and do additional. Of course, you did perfect job and not critiquing, but just as an option, additional corridor is very feasible by doing this maneuver.
I understand. Yeah, I do that sometimes here more because of the goal was more partial and just collect a confirmatory diagnosis. That's why we just went through lamina terminalis directly there. One thing though, when we go outside, you have to remember there might be a layer of hypothalamus there, to enter the tumor outside. But I agree with you, like that, taking the clinoid, I do use that technique for depending on the circumstance. I think before we finish here, I would like to hear Dr. Landero to give us an overview, and then I think we can declare it done for the day after that. Can you unmute?
Unmute.
Microphone, doctor.
Yeah.
That's okay?
Yes.
Danny, thanks for inviting me. That's incredible section. The two first cases is very interesting. Congratulations, Francisco, both Francisco. And the last case, as you show, I have the same comment as our friend Kenan. If you did a small craniodectomy, you can gain space and manipulate the optic nerve on this right side better than you gain space and you can manipulate and spare the optic nerve much better. That's my only comment.
Sounds good. Dusik, what do you want to finalize?
Yes, but we have a very excellent cases of 3 persons, and then so we all participants enjoyed these 3 surgical cases, and so let's finish this craniopharyngioma, and then so what is we have to make schedules for next the meeting.
Yeah, we'll discuss and announce for next month. And for those that didn't have a chance or just came late, we'll post the recording on the YouTube where people can watch over the month and for the future as well, the beautiful discussion that we had. So thank everybody and appreciate a special thanks to Natalia who put all together.
Yeah, thank you, everybody.
Yeah, thank you,
Thank
Natalia.
Thank you for all. Thank you for all.
Thank you,
No,
Kenan.
you're
Appreciate
welcome.
your presence.
You guys have a good weekend.
Good.
Thank you. Okay, bye-bye.
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 Bye. Have a good day.
Bye. A good day for all.
Yeah.